Hi folks, I hope you're doing good and thanks for connecting back on this rheumatology section of Prepladder NEET SS. This is Dr. Santosh Patil and in this video we will be studying about psoriatic arthritis. Now I'm sure you all know that psoriatic arthritis is a kind of arthritis that occurs in the backdrop of psoriasis, but to be more precise, this is classified under peripheral spondyloarthritis because it shares those characteristic binding features that we discussed in the ankylosing spondylosis video. Right? But there are certain exceptions here. So this does not follow all the rules of those peripheral spondyloarthritis. What are the exceptions? Generally, when I say peripheral spondyloarthritis, we know that upper limb involvement is less common than lower limb, right? So it is predominantly affecting the lower limb joints. But in case of psoriatic arthritis, upper limb is more affected, hand joints are more affected than the lower limb joints. The exception number 2 is that in case of psoriatic arthritis, it is usually affecting small joints. But in case of all other peripheral spondyloarthritis, that the characteristic involvement is large joints more than small. But in case of psoriatic, the small joint involvement is characteristic more than the large joint involvement, right? So that is what sets it apart from the other things. And from that perspective, it resembles rheumatoid arthritis more than the other peripheral spondyloarthritis, right? So rightfully so, rheumatoid arthritis should always figure in as one of the important differential diagnoses. Okay. Now, if we see the patients of psoriasis, we know that the epidemiology says 1% of the general population has psoriasis, right? So the prevalence of psoriasis is around 1%. And roughly 1/3 of those patients may have a tendency to go on to develop the psoriatic arthritis. The numbers vary depending on which is the source and what study you're quoting. Some books mention as low as 5, some go on to mention little higher. So roughly you can say 5 to 30% of the patients of psoriasis go on to develop psoriatic arthritis. Okay. Now usually I have already told you that rheumatoid arthritis is one of the important differential diagnoses. But one thing that we should note about psoriatic arthritis is this is more severe and more mutilating than rheumatoid arthritis. Rheumatoid arthritis is characteristically known for the deforming, joint deforming changes, right? But in case of psoriatic arthritis, those deformities or deforming activity is more vigorous. So this is going to be more mutilating than rheumatoid arthritis. Okay. Now coming to the epidemiology of this disorder, just like any other peripheral spondyloarthritis, as such spondyloarthritis, males are more affected than females, even in case of psoriatic arthritis. Okay. The usual age group of presentation is somewhere between 30 to 55 years of age. Yes, I agree. From pediatric age group to relatively elderly people, you may see psoriatic presentation, but majority of the patients present in this age range of 30 to 55 years. Okay. And if you look at their family history, 30% of the patients of psoriasis generally have a family history, first or second degree family member who is also suffering from psoriasis. I'm talking about psoriasis per se, not psoriatic arthritis. Okay. So roughly 1/3 of the patients have a family member who is also suffering from psoriasis. And if you look at the concordance rate among monozygotic twins, right? For psoriasis, the concordance rate is quite high. 30 to 70% is the concordance rate for psoriasis. The concordance rate is relatively low in case of psoriatic arthritis, ranging for around 10 to 30%. Okay. But one thing is very clear from this, that 1/3 of the patients have family history and there is a very good concordance rate in monozygotic twins. That means that genetics plays an important role, right? So we will be discussing a little bit about genetics in the next slide. But before I move on, let me draw your attention that HIV has a strong correlation with the risk of development of psoriasis. And once the HIV patient develops psoriasis, the risk of this progressing to psoriatic arthritis is high. Thus, HIV increases the risk of developing psoriasis as well as psoriatic arthritis. And once the psoriatic arthritis sets in, it also determines the severity. So, HIV patient developing psoriatic arthritis is going to have a more severe illness, right? Severe illness among HIV positive patients. Okay. Now talking about the genetics, I have already told you this is something I consider as an important point for MCQs. So the first HLA I'm talking about is HLA-CW6. HLA-CW6 is characteristically associated with psoriasis, right? This is that characteristic HLA variant that is associated with psoriasis, and obviously a reasonable number of patients would be positive for this. Okay. Now moving on to discuss the other HLA variant, like one thing is very clear, right? If there is a classical HLA variant that the examiner is asking about, which is associated with the risk of psoriasis, you have to go with HLA CW06. Even if they mention HLA-B27 and they're asking about the psoriatic arthritis, right? Even in that case, I would say go with HLA-CW because it is seen in more number of patients. Okay. Now, if I were to talk about the HLA-B27, right? 50 to 70% of the patients with axial manifestation, in the sense psoriatic arthritis with the axial joint involvement, are positive. On the other hand, if you look at the number of patients with peripheral spondyloarthritis secondary to psoriasis who are positive for HLA-B27, the numbers are just 20%. Right? So that simply goes on to say that HLA-B27 confers higher risk of developing axial spondyloarthritis. Right? Okay, there is one more genetic HLA variant that is found to confer higher risk from recent studies, that is HLA-B39. Right? So this also confers higher risk of developing axial spondyloarthritis. The other HLA variants which are associated with psoriasis include HLA-DR7, DR3, 38 and a recently reported HLA-B08. Right? So I expect you to remember all of these because MCQs can be asked from this. Right? So all of these I want you to remember: DR3, DR7, 39, B39, B38, B08, B27, CW6. Right? These two, anyway, you have to remember. We don't have a choice about that. Okay. Now coming to discuss about some non-HLA loci. Right? Apart from this HLA loci, there is also risk conferred by certain non-HLA loci, which include TNIP1. I think you might have heard it once or twice from my mouth in previous videos. Right? Apart from that, certain mutations and polymorphic variations of interleukin 23 receptor and TNFA-IP3, right? So these genes can confer higher risk of developing psoriasis. Okay, so these are the non-HLA loci I want you to remember. Now talking about the clinical features. Okay, so remember one important point. Not all patients have psoriatic skin rash at the time they present with psoriatic arthritis, right? So only 2/3 of the patients have psoriasis preceding the arthritis. So they develop psoriasis and then they later on manifest with arthritic manifestation. That the story holds good for 2/3 of the patient. Among the remainder of the patients, what is the story? 15% of them have psoriasis occurring and psoriatic arthritis occurring within 12 months of each other. Matlab, psoriasis occurs within 12 months, patient develop arthritis, or arthritis occurs within 12 months, patient develop skin rashes. Both are clubbed within 12 months of time, right? Those cases, I can say they are simultaneous in onset. On the other hand, in the remaining patients, psoriatic arthritis precedes skin changes by more than 12 months. And this story is more classical of children. So in pediatric age group, the presentation in the form of psoriatic arthritis preceding the skin changes is more common in comparison to the adult population. I hope you have got the point. Okay, so now let us go on to discuss the clinical features. So far we know the epidemiology, we know the characteristic genetic changes that are associated with this disease. Now let us discuss the clinical features. We will begin that with skeletal manifestation because obviously we are talking about arthritis, right? So in case of psoriasis, the skeletal manifestations can be discussed under 5 distinct types of joint involvement. Now, there would be significant overlap of these presentations, but books continue to describe these 5 distinct types. Okay, what are the 5 distinct types? The type number 1, I think something that is very characteristic of psoriasis, that is the DIP arthritis, isolated distal interphalangeal joint arthritis, which is seen in 15% of the patients. Okay, where else we hear DIP involvement? Right, you're right. So we hear DIP involvement in case of osteoarthritis also, right? So that is one type. Then the second variant is asymmetric oligoarthritis. Asymmetric oligoarthritis. If you are a very stern follower of Harrison, he says it is seen in 30% of the patients, but most of the rheumatology text and the latest literature doesn't agree with this. Actually, the text and literature says that this is the most common type of arthritis that we see in patients with psoriasis or psoriatic arthritis. This is the most common form. Okay. According to most of the literature, they go on to mention that as much as 60 to 70% of the patients would present with this presentation. right? So my recommendation is, if there is an MCQ asking you what is the most common, I would say go with asymmetric oligoarthritis rather than going with Harrison, which says symmetric rheumatoid arthritis like arthritis as the most common, going by his number of 40%. Right? That is what Harrison gives. But I would strongly urge go with asymmetric oligoarthritis as the answer if there is a question about it. Okay. So now we already know 3 types of presentation. The fourth one is axial, mainly spondylitis, right? So that is seen in around 20% of the times. In that case, cervical joint involvement is common. And if at all the sacroiliac joint is involved, the involvement is usually asymmetrical. We are generally talking about symmetric sacroiliitis, but in this case, it is going to be asymmetric, right? The last one, probably the rarest one, that is arthritis mutilans. What happens in mutilans? There is mutilating joint changes, right? So more aggressive joint disease, which is quite rare. So seen in around 5% of the patients. Okay, so these are the 5 distinct types. Before we move on to discuss the radiological features and the extra articular manifestations, I want you to remember these 3 points. What is that? Joints typically involved in psoriatic arthritis, which are not characteristically seen to be involved in other joint disorders, right? The first one is distal interphalangeal joint. We know the only other close differential diagnosis I would think of is osteoarthritis, right? The nodular hand osteoarthritis. Okay. Other than that, temporomandibular joint involvement is also very characteristic, and manubriosternal joint involvement, that is also very characteristic, right? So these 2 I want you to particularly remember. Now coming to extra-articular manifestations. What are the extra-articular manifestations we know? Okay, so let us begin with nails. I know skin involvement all of you know, so I'm not going to deliberate about it, but we'll begin with nail changes. So be aware that nail changes are seen in almost all patients with psoriatic arthritis. Nail changes may not be seen in all patients with psoriasis. So there maybe it is seen in around 40 to 80% of the patients, but 95 to 100% of the patients of psoriatic arthritis have nail changes. What are the characteristic nail changes? The number 1 is pitting, right? Pitting of the nails. And this, more the number of pits, that strongly correlates with psoriasis and the risk of developing psoriatic arthritis. So generally some of the resources say that more than 20 pits strongly associated with the risk of developing psoriatic arthritis, right? More than 20 pits per nail is strongly associated with the risk of developing psoriasis if the skin changes are already not evident, and also the risk of developing psoriatic arthritis. We can clearly appreciate the characteristic psoriatic pits, right? And definitely you can notice that in both these nails, the numbers would probably easily exceed 20. Okay. Other than that, we can also notice onycholysis, yellowish discoloration of the nails, and also hyperkeratosis. Those changes you can appreciate in the adjacent image, right? You can appreciate in this image. Hyperkeratosis, distal yellowish discoloration, and onycholysis. So before we move on, just let me reiterate again. Nail changes correlates with the psoriatic arthritis risk in psoriasis patients, right? Okay. Now coming to the next manifestation, that is ocular, right? So what are the ocular changes we notice? Uveitis is known to occur just like in case of any other spondyloarthritis conditions, but generally when we say spondyloarthritis condition, it is usually anterior, right? But in case of psoriasis, it can cause both anterior and posterior. Now I do agree that there are some sources which say posterior is more common, but I have gone through the literature. Overall, it is evident that anterior uveitis is more common even in case of psoriasis. But posterior is something which is not routinely seen in other spondyloarthritis conditions, but here it is seen. So we can see both anterior as well as posterior. And generally, whether we talk about anterior or posterior, when we say spondyloarthritis, say for example, I'm talking about ankylosing spondylosis, I've told you that it is kind of cyclical. So the recurrence is known to occur. So if, for example, the right eye is first affected, then when it resolves, the left eye gets affected. The recurrence is on the opposite side. So it is kind of cyclical or alternating. So in case of psoriatic arthritis related uveitis, it is generally bilateral, so that cyclical doesn't come into picture, and this is usually going to be chronic. So it is bilateral and chronic. So that is one more feature that sets it apart from other spondyloarthritis. Then there is also propensity to involve aorta in the form of aortitis, and this can also go on to cause aortic regurgitation. Okay, so these are the extra articular manifestations. Obviously, I have not discussed the skin changes. I believe that it would be covered in the psoriasis video, and I'm also sure that you are all very much familiar with that. Okay, coming to evaluation, right? So if we do the laboratory evaluation, because this is an aggressive disease, ESR and CRP are very often elevated. This is also an inflammatory arthritis, right? So ESR and CRP is very often elevated. And some forms, especially the severe forms of the disease, are often associated with hyperuricemia. And this is one important MCQ point. I have noticed MCQ centered around this in the Central Institute's entrance exams on the rheumatology paper as well as in general medicine. So I want you to remember, severe forms of psoriatic arthritis are associated with hyperuricemia. Characteristically, psoriatic arthritis is supposed to be RA factor negative, which is true. But Harrison mentions that in some patients there may be low level RA factor activity. Anyway, broadly speaking, it is RA factor negative, right? But 10% of the patients may have anti-CCP antibody positivity. And these numbers I'm quoting from Harrison itself, right? So RA factor is characteristically negative, but a minuscule number of these patients may have anti-CCP antibody positivity. Okay. So that's all about the basic laboratory tests. Now talking about the radiological features. So we know the joint involvement. Now let us see the characteristic radiological features which are associated with psoriatic arthritis. The first thing that should come to our mind is obviously pencil cup deformity, because that is something which is characteristic of psoriatic arthritis, right? So you can appreciate the pencil cup deformity from this image, right? As if there is a pencil which is placed in a cup, right? So this is what is known as pencil cup deformity. That is one thing which is characteristic. Second thing, we can also notice marginal erosions. So if to show, I don't have a proper image here, but you would notice the erosions in the margins, marginal erosions with adjacent bony proliferation. Right? This is what we call as whiskering of joints. That is one additional finding we can see. Then moving on further, right? Small joint ankylosis is characteristic. Right? Fusion of small joints. So we know that hand joints are more affected. Small joints are more affected than the large joints. So those joints can develop ankylosis. We already know that characteristically, when we say psoriatic arthritis, we are expecting the proximal interphalangeal joint and distal interphalangeal joint to be characteristically affected. Right? In case of rheumatoid arthritis, it is more about metacarpophalangeal and PIP. There is pairing of DIP, right? DIP is not going to be involved there. So here DIP plus PIP with relative less involvement of the metacarpophalangeal joint. But fusion of small joints is something which is known to occur in most of the inflammatory arthritis. It can occur here also. Okay, this is not characteristic, but it is known to occur. Then the next thing is arthritis mutilans. Right? This variant of thing is only seen in around 5% of the patients, but when it is there, it is very characteristic. Right? So what do we see? There is mutilation, or there is a severe joint degeneration leading to mutilation and various deformities. Right? So there you may also notice acral osteolysis. So there may be bone loss in the distal parts of the finger. So this bone loss and the joint degeneration can sometimes lead to something known as telescoping of fingers. Okay, now what do I mean by that? You know telescope, right? So when you're looking at a distant object, you can stretch it out or put it back. Right? You can increase or shorten the length of the telescope, right? The viewing chamber. Similar to that, the affected joint digits can be shortened or lengthened. And that is what is known as telescoping of fingers. That is because of the severe mutilating arthritis. So the joints are severely damaged and fingers can be pushed in or pushed out. You can probably appreciate that from this image, right? Look at the image 1. Let me call this image 1. Like if you look at the image 1, look at the finger that he is trying to stretch. So now it is in a particular position, but he is able to stretch it out. Later he will be able to push it back, right? Because joints are going to overcrowd over each other because of the instability or destruction of the joints, right? The bones are going to override over each other. That is what is known as telescoping of fingers, which is something characteristically associated with, I'm using the word characteristic, it is characteristically associated with psoriatic arthritis. That much of mutilating ability this joint disorder has. Okay. One more thing about the radiological involvement, or I should say even clinical involvement, is the ray pattern. Ray pattern of joint involvement. Now, what do I mean by ray pattern? Which is also characteristic of psoriatic arthritis. I can say this kind of involvement is not commonly seen with other spondyloarthritis or other small joint disorders. Okay. Now, what do I mean by ray pattern? Typically, in ray pattern, what happens is, if a joint of a particular digit is affected, right, there will be involvement of all or multiple joints of the same digit, and the adjacent digit may be unaffected. It is like one ray. So, for example, I don't have an image to show you, but you can simply understand ray means, like you can say a ray is going through a typical digit, right? So only one digit, multiple joints are affected, the adjacent may be unaffected. Even if it is affected, it is going to get affected later on. So it is like one which is characteristically affected, then we call it as ray pattern. Okay? So ray pattern is characteristic of psoriatic arthritis. So that is about radiological manifestation. What else we see? We see something characteristic of characteristic of psoriatic arthritis, that is ivory phalanx. Okay, what is that? Obviously, we are talking about phalanx, so it has to do something with phalanx. You can appreciate that in this X-ray. If you look here, you might notice that it looks like ivory. I know the image is not very clear, but there is diffuse sclerosis. I'm not talking about the joint line sclerosis or subchondral sclerosis. I'm talking about the diffuse sclerosis of a particular phalanx, right? So this phalanx looks so different from rest of the phalanx. There is a diffuse sclerosis, like there is a trabecular network like sclerotic changes, right? So this kind of looks like the ivory of a tusker, right? That is why this is known as ivory phalanx, which is kind of characteristic of psoriatic arthritis, not routinely seen with other types. Okay. So far we have discussed about the involvement of the peripheral joints, right? Now let us talk about the axial involvement. I've already told you that HLA-B27 positivity confers higher risk of axial involvement, right? Now the things that differentiate it from ankylosing spondylosis is the asymmetry of sacroiliitis that we see. So in case of ankylosing spondylosis, it is usually going to be symmetric. Asymmetry can occur there also, but as a rough rule, it is usually symmetric. Here it is asymmetric. So even the axial involvement is in the form of asymmetry. So asymmetry, whenever you see that, you should suspect that it could be a psoriatic spondylitis, right? The second thing that helps us to distinguish is the nature of syndesmophytes. Syndesmophytes in case of ankylosing spondylitis are more characteristically marginal, and they are generally delicate. But in case of psoriatic arthritis, you do see both marginal as well as non-marginal. But this non-marginal is something which is characteristic. Right? Non-marginal is something which is characteristic, which are often asymmetric. They are generally bulky. So symmetry is what we generally anticipate when we say ankylosing spondylitis, but here it is asymmetrical. Then they are more bulkier than what we see, the characteristic marginal syndesmophytes that we see in ankylosing spondylosis. Compared to that, these are going to be more bulky, and they are generally less delicate. Right? They are generally less delicate. Probably you can appreciate from this image if I have to show you. So you can notice that there are syndesmophytes, but they are definitely asymmetric. Look at here, or compare it with the syndesmophyte here. You can notice that this is much thinner, this is much bulkier. So there is asymmetry, something that is characteristic of psoriatic arthritis. Okay, so I hope I have made the point clear. The differentiation between ankylosing spondylitis and psoriatic arthritis related spondylitis, right? Okay, so mainly it is about the asymmetry and the nature of syndesmophytes. So I want you to remember this, because again, I do sense that MCQs can be asked from this. Okay, now coming to diagnosis. So far we know what is the biochemical abnormalities we can anticipate. We know the radiological changes that are characteristically associated. Just to summarize, the ivory phalanx is one thing we know. We know the axial involvement and asymmetry. We know that there will be joint mutilation. We know that there may be a ray pattern of joint involvement, and joint mutilation might lead to telescoping of fingers. And we also know that the characteristic common deformity that is known as pencil cuff deformity. We know something about whiskering of joints, right? So I want you to remember these points. These are important radiological points. So the diagnosis is obviously clinical, but nonetheless we have this classification criteria called CASPR, which you are all familiar with. has a sensitivity and specificity exceeding 90%. Its specificity is almost 99% and sensitivity is 91%. So because of such high sensitivity and specificity, this can be utilized even for clinical practice. I know it is a classification criteria, but because of its high sensitivity and specificity, it facilitates early diagnosis of psoriatic arthritis, and many practitioners continue to use it as their clinical tool for diagnosis. So what is this Casper classification criteria? I think this was proposed probably in 2006, if I am not mistaken. In the Casper criteria, we would classify a patient as having psoriatic arthritis if there is inflammatory articular disease with more than or equal to 3 of the 5 points mentioned below are satisfied. So there are 5 characteristic points mentioned here, and if patient satisfies or gets 3 points from this, we would be classifying it as psoriatic arthritis. Okay, so all the points that are mentioned here generally are weighed for 1 point with one exception. If patient is having current psoriasis, that gets 2 points. That is one exception. Otherwise, all the points we would be discussing now carries 1 point, right? So let us begin with the point number 1. Patients having current psoriasis. I have already told you 2 points. Other than that, if there is personal history of psoriasis, it's like a past history of psoriasis, now may be under remission or under treatment and the manifestations may be absent, then we would be giving 1 point. Or if there is a family history of psoriasis, we would be giving 1 point. That is the first point. Now, the second thing is about nail changes. Typical psoriatic nail dystrophy. We know what are the typical psoriatic nail dystrophy changes. We have just discussed that, right? So that should be present on current examination, not the documented evidence of nail dystrophy. Currently, there should be evidence, clinical evidence of nail dystrophy. That would score 1 point. Now, we already know that in case of psoriatic arthritis, we are anticipating the RA factor to be negative. I have told you some percent of the patients may have anti-CCP activity, but RA is expected to be negative. So that gets 1 point. That is our third point. Now, the fourth point is about dactylitis, right? So there should be either current dactylitis, which you are examining as the doctor, or there should be history of dactylitis, which has been documented by a rheumatologist. I don't know why they specifically mention a rheumatologist instead of saying a physician or something like that, but that is what the guideline is about. Dactylitis documented by a rheumatologist. And the last one is radiological features, radiological evidence of extra-articular new bone formation. So from these 5, if patient scores 3 out of the 5 points, then we would classify the condition as psoriatic arthritis. Okay, that's about the diagnosis. Now coming to management, right? So one important thing we should know is generally we should be addressing both skin as well as the joint disorders if they are having both, right? So therapy should be directed at both skin and joint diseases. Like if one particular class of drug is going to work for both, it is better to go with that rather than trying to address them separately, right? NSAIDs are obviously useful, just like any other spondyloarthritis. They do help in terms of management of pain, as well as if there is stiffness, they are definitely helpful. They definitely can address the joint change or joint disease, but they cannot address the skin changes, right? So NSAIDs are more of additional drugs here. The mainstay of treatment, when you say we want to treat both joint as well as the skin changes, is anti-TNF alpha drugs, right? So this is the mainstay of treatment currently, and they have shown remarkable efficacy in terms of resolution of skin disease as well as improvement of the joint disease, right? So they are effective at both the sides. When anti-TNF alpha therapy fails, for example, you are started with infliximab or etanercept and you're not getting the desired result, in those cases you can think of little additional drugs. In the sense, you can use ustekinumab, which is a interleukin 12 and 23. It's a combined interleukin 12 and 23 antagonist. It's a anti-IL-12 or 23 monoclonal antibody. The other monoclonal antibody is secukinumab, which is an anti-IL-17A monoclonal antibody, right? So these can be used when the TNF alpha therapy, anti-TNF alpha therapy has failed. There is also one more drug which is called as apremilast, right? Apremilast, which is a phosphodiesterase 4 inhibitor, right? It's a PDE4 inhibitor. All our sildenafil, tadalafil, they are all PDE5 inhibitors. This is a PDE4 inhibitors, which is useful. This is definitely not as effective as the biologicals or anti-TNF alpha drugs, but nonetheless, this is relatively more safer, and this safety profile makes it a little more attractive for the treatment. It can be used, it is helpful, but it is useful when there is no radiological evidence of joint damage. Once the joint damage has occurred, once you start noticing that there is arthritis mutilans, or if there is already fusion of the joints. In such situation, this is not helpful. So it should be started much earlier, before there is radiological evidence of joint damage. Only clinically diagnosed as psoriatic arthritis, there is no radiological evidence of joint damage. In those patients, it can be used. This is also not suitable to be used in patients with axial involvement, right? So there also it is generally not useful. Okay. The last drug that can be found helpful is leflunomide. Right? So leflunomide is also useful in both axial as well as peripheral arthritic variants. Right? So this is more useful for management of arthritis rather than the skin changes. Okay. So that's all from me, guys, on this video about psoriatic arthritis. So we have covered all the important points that you should need to know from the examination perspective. And before I wind up, I'll just give you a quick recap. Right? The important points to note is that this is a disorder where males are more affected than females. Right? There is a significant familial history and the concordance. The HLA variant that is characteristically associated with psoriasis is HLA-CW06, and patients with this disorder may have HLA-B27 positivity. Positivity correlates with the risk of developing axial spondyloarthritis. Right? And in terms of clinical features, psoriasis occurring first and then psoriatic arthritis developing later is the commonest presentation, but nonetheless in some patients there can be co-occurrence, and in some cases it can predate or antedate. Right? First arthritis manifests and then psoriatic skin lesions appear. That is typically seen in children. In terms of skeletal manifestations, I've already discussed you, there are 5 distinct types. Right? The commonest one is asymmetric oligoarthritis. Right? Then involvement of DIP, temporomandibular joints, and manubriosternal joints. These are typically associated with psoriatic arthritis, relatively less commonly reported from other types. Extra-articular manifestation, nail involvement strongly correlates with the risk of developing psoriatic arthritis. Right? This we have already discussed. In terms of ocular manifestation, anterior uveitis is the most common ocular manifestation. Right? So these are the extra-articular manifestations. In terms of evaluation, I have already told you, I particularly want you to remember that this condition is associated with risk of hyperuricemia, especially in severe diseases. Radiological features, pencil cuff deformity, characteristic. Marginal erosions with adjacent bony proliferation, very well known to occur. Small joint ankylosis, not characteristic. There are various other disorders like rheumatoid arthritis also may cause small joint ankylosis, but yeah, this is also something seen in these patients. Arthritis mutilans, ray pattern of distribution, telescoping of fingers, yes, these are all characteristic. Mutilans, ray pattern of the joint involvement, and telescoping of fingers, right? These are all characteristics. Ivory phalanx, again, ivory phalanx is characteristic of the psoriatic arthritis. In terms of axial involvement, less common in comparison to the other spondyloarthritis, and asymmetry is the norm, right? Rather than having symmetry, asymmetrical sacroiliitis, asymmetric spondylitis, having non-marginal syndesmophytes, which are again asymmetric, bulky, and less delicate. Diagnosis, clinical, Caspar criteria is something we should know, right? Inflammatory articular disease with 3 or more than 3 of the 5 points that we have already discussed. The first point about the type of the psoriasis, whether it is current, personal history or family history, nail changes, RA factor negativity, dactylitis, current or past dactylitis documented by a rheumatologist, and the last one is radiographic features of extra-articular new bone formation. So this is the Casper's criteria. Talking about management, NSAIDs are useful for management of the joint disease. They're not helpful for skin. So the mainstay of treatment currently is anti-TNF alpha therapy, right? If it fails, you can use other monoclonal antibodies like ustekinumab or secukinumab. And sometimes when there is no radiological evidence of joint disease, you may use apremilast, which is a PDE4 inhibitor. And also the joint disease can be managed with leflunomide, right? Okay, so that's all for guys. This last session of last 2 or 3 minutes, whatever I was uttering about, you can use it for revision. Like, so when you come back to this video, I will make an attempt to summarize whatever we discussed in last 2 or 3 minutes, which can give you a essential glimpse of the video. So you can visit the last section of the video and revise whenever you feel like. Thank you guys.